Dear audience, let me introduce my PhD topic, which is psychological aspects of health promotion and disease prevention. My name is Zsófia Németh. I'm a psychologist. I'm working at the Institute of Pancreatic Diseases at Semmelweis University. My supervisors are Andrea Szentesi and Péter Hegyi. My scientific methodology supervisor is Jimmy Lee. My vision is an evidence-based healthcare system that bridges mental and physical health, promoting the well-being of individuals and communities. And my mission is to promote psychological research for better patient care and explore the potential of psychological interventions. To achieve my vision, I have 3 ongoing projects which I would like to show you today. The first will be investigation between the eating disorders and gastrointestinal disease. The second one will be an examination of the effect of social support. And the third one will be investigation of diabetes preventive possibilities after pancreatitis. My first project is investigating the prevalence of gastrointestinal disease among patients with eating disorders. Eating disorders are psychiatric disorders with the highest mortality rate. In the general population, the prevalence is 8%, but in gastroenterology practice, it's higher. We know that there's a bidirectional relationship between the two diseases. Eating disorders can cause GI symptoms, and GI disorders and symptoms can lead to disordered eating habits and eating disorders. And why is it a problem? Because patients with eating disorders usually receive late diagnosis, and because of them, 90% of them remain untreated, and up to half of them never achieve recovery. Because of this, our aim is to investigate the prevalence of GI disorders among patients with eating disorders. The clinical question is that what is the prevalence of GI disease in patients with eating disorders? We hypothesize that there is a high prevalence of GI disorders among patients with eating disorders. We conducted the systematic search last year, November, in 3 big databases with the search key, 2-domain search key. The first domain refers to eating disorders, and the second one refers to gastrointestinal disorders. We had more than 12,000 articles, but after the selection process, we had 130. Now we have some preliminary data and figure which I would like to show. In this figure, you can see the prevalence of functional gastrointestinal disorders in anorexia nervosa. The importance of it is that functional gastrointestinal disorders are common gut-brain axis disorders causing GI symptoms without any structural or biochemical abnormalities. Reduced lower quality of life. In this figure, the unit is percentage. It can be between 0 and 100. You can see that it contains 13 articles with more than 1,200 anorexia nervosa patient data. The used studies were cross-sectional. The heterogeneity is quite high. It can be because of the differences in the examined population, for example, in gender, age, and the different diagnostical criteria of the eating disorders and gastrointestinal disease. In this figure, you can see that the prevalence of functional gastrointestinal disorders in anorexia nervosa is 63%, which is clinically relevant, and this suggests that it's important to screen the patient with eating disorders, and it's important to treat their gastrointestinal disorders as well. Organic gastrointestinal disorders are medically identifiable characteristic of the digestive tract, for example, inflammatory bowel disease, gastritis, ulcerative colitis, and in this figure we can see that the prevalence of it in anorexia nervosa is 9%, which suggests that it's not that essential to screen the patient for this kind of disorders, because in the general population the prevalence is the same. We can see that the heterogeneity is high. It can be due to the previously mentioned reasons. In this summary table, you can see the different prevalences in different kind of GI disease and different kind of eating disorders. In the first part of the summary table, you can see the functional gastrointestinal disorders, the bowel disease, gastroduodenal disease, esophageal disorders, and in the other part of the summary table, you can see the organic GI disease. And in the first line, you can see what kind of eating disorder was examined. Now we are working on the risk of bias assessment and in the figure and table part. My second project is investigating the effect of social support on lifestyle risk factors and chronic disease among European citizens. We know that 35% of the European population reported having some kind of chronic health problem. We also know that lifestyle risk factors, for example, unhealthy diet, sedentary lifestyle, smoking, alcohol consumption, are connected to the chronic conditions, but we also know that changing our lifestyle is not that easy. Our aim is to investigate the role of social support in lifestyle risk factors and in chronic disease. The clinical question is that does social support influence lifestyle risk factors? Our hypothesis suggests that yes, social support is associated with lower prevalence of lifestyle risk factors and chronic disease. And the clinical implication is that if we are right, we can promote social support, we can involve family members, we can create therapy groups in order to reduce the lifestyle risk factors and the prevalence of chronic disease. We know that our topic is feasible, we prepared the research proposal, and the data request will be sent soon to the Eurostat office. My third project is investigating diabetes preventive lifestyle intervention after pancreatitis. Acute pancreatitis goes with high mortality rates, and the incidence of the disease is growing. We know that up to 40% of the patients after acute pancreatitis develop post-pancreatic diabetes mellitus, which is connected to higher severity and higher mortality rates of acute pancreatitis. The problem is that these patients are high-risk population for diabetes, but this knowledge is totally missing from the guidelines, and there is no established protocol. And our aim is to determine the best lifestyle intervention to prevent diabetes after acute pancreatitis. We have two clinical questions. First of all, are complex lifestyle interventions an effective way of preventing diabetes after acute pancreatitis? And the second question is that what kind of resources should the healthcare system provide for complex lifestyle intervention? As I mentioned, we would like to examine patients after acute pancreatitis without diabetes, and we would like to create different type of intervention for them. And our hypothesis is that complex lifestyle intervention is the most effective way of preventing diabetes. So, we would like to create 4 different intervention groups. The first group would receive a multidisciplinary intervention from a doctor, from a dietitian, from a physiotherapist, and from a psychologist. The second group will receive an intervention from one expert of the field. The third group would receive an information booklet about the possibilities, and the third group would receive the standard care. And as outcome, we would like to measure hemoglobin A1C levels. So I have this 3 ongoing projects. I would like to finish the first one this year, and after I will focus more on the second and third project. And I would like to finish my presentation with the slogan of the World Mental Health Day. Remember, it's okay not to be okay. You can heal your mind and shine your light. Thank you for your attention.
I would like to ask regarding your second project about the Eurostat database, like what was your strategy and the way you did it?
Okay, so Eurostat is the statistical office of the European Union. Their mission is to provide high-quality statistics and high-quality data, and it's open for everyone. So if you are a researcher, you can create a plan and you can ask for the data. And yes, it's a quite long process to receive it, but I think it will worth doing it.
My question would be about the first project. I'm just curious, how would this change the physiotherapy if a patient with eating disorder has gastrointestinal symptoms? Or do you do anything differently in this case? Thank you.
Yes, there are some studies that a lot of people suffering with different type of eating disorders not ask for help for their gastrointestinal symptoms, and these will worsen the symptoms and cooperation with the whole treatment. So we think it's very important to check all of the possibilities we can do, and from the data, from the preliminary data we have, we know that this gastrointestinal disorder frequency is very high, so we have to cooperate with the gastroenterologist.
What is your definition between the difference? How do you define the difference between disease and disorder? Because I feel that you use it a little bit confusingly interchangeably.
Yes, maybe it was my fault. Eating disorders are the official name of the disease, and we have this information from the DSM-5, which is the Diagnostic Manual of Mental Disorders, and yes, these are eating disorders, so maybe I changed the word sometimes.
Yeah, so organic is always a disease, is never a disorder, and we don't use anymore the FGID. That's the new name for this is the disorders of the brain-gut interaction. Okay. That's the correct name. What do you think the health problems in the European Union, that 35% of health problems, what could be the effect of the social media and the internet?
Yes, it has a very big impact on it. And we know that in the background of the chronic disease, these lifestyle risk factors are standing, and of course we spend more hours, or the general population spend a lot of time using internet or watching film or something like that. So yes, I think it made our life more sedentary, without activities. How to say, I don't have a concrete knowledge about this, but it's clear that there's a connection between the internet and social media, and between the chronic disease. But of course, social media and internet has a huge amount of positive effects on our health. So I wouldn't consider it as a bad guy in this story.
And do you think that AI might help you in the future?
I don't know. I hope so.
Try ChatGPT.
The lifestyle interventions are physiological interventions, or what kind of interventions?
Yes, we would like to do this in a multidisciplinary team with a dietitian, with a physiotherapist, and with a psychologist as well, because from the literature of psychology we have evidence that psychological support can be a very important part of the lifestyle changes. For example, we can have the patient to set realistic, achievable goals, and with cognitive behavior therapy we can help them through this process.
Are you doing this in